Hi, this is Brad, and this is my submission for the Unit 1 Peer Competency Case Study for DPT 661. So, my hypothesis regarding this patient is that he's stuck in a position that's comfortable for him, which is flexion at the kind of upper thoracic and lower cervical spine, and left cervical side bending, and stuck away from positions that lead to pain, such as extension and again in the upper cervical spine and lower cervical spine. Also, right cervical cervical side bending gives him some pain. The cervical, I hypothesize a cervical radiculopathy. Possibly his spondylosis might have been leading to this. Also, possibly osteoarthritis might play a role in his spondylosis. So cervical side bending to the right closes that gap on the right and maybe compresses some of those nerve roots, causing the radicular symptoms that he's having. So he kind of wants to stay away from that side, and might be stuck in a position where he's been doing that so long now that he's stuck in a position that he can't really go to the right side. He's limited in that right side bending. And then using the SIN model, I classified him as low severity because it says symptoms are annoying, but don't limit his function or vocational tasks. And then I said minimum irritability using the functional classification because the patient said that he can do anything he wants, but might get increased pain following longer duration activities. And I didn't use the Syriax model for this because it didn't really say anything about when in the range of motion he has those symptoms. And then as far as nature, I said kind of a mix of mechanical and neurological because his symptoms are reproduced with movement, like right cervical side bending and cervical extension. But the types of symptoms or the quality of the symptoms are neurological because he has radicular symptoms with going down into his right arm with right cervical side bending. So some other exam pieces I might want to do with this is possibly palpation of the midline of the cervical spine, just to make sure, but I wouldn't go through the whole Canadian cervical spine rule because I don't really suspect a fracture. I would want to know more about his radicular symptoms, like the quality and the quantity of his cervical range of motion. And then again, just to give more information on the irritability status when he feels his symptoms throughout the range of motion. Since my primary hypothesis is a radiculopathy, then I would do a Sperling's test bilaterally and cervical distraction to screen for that. And I said bilaterally just to compare side to side, and kind of I think it could be used as kind of a teaching method to the patient to let them know that when I do this motion, it reproduces your symptoms on this side, but when I go to the other side, then it's fine. And then I would also want to get a better idea of his thoracic mobility. So I know it said he did PAs with the thoracic segments, but I might also do active passive range of motion and overpressures, which I think would give me a better idea of the functional impact of his hypomobility. And then a couple other things I might do are upper limb neural tension, take vitals, and ask if he has any other symptoms such as headache or lightheadedness, just so that we're steering clear of any like VBI issues or anything like that. As far as initial treatment, some of the problems he is having, which I kind of stated before, but just to go over those again. painful with right cervical side bending and cervical extension. And then he has a forward head posture with limited cervical lordosis. So to back up my plan for this initial session, I'm using the treatment-based classification system from the clinical practice guideline. And using this, I feel like this patient most closely fits in the category of neck pain with mobility deficits. And then I'm also in the clinical practice guideline, it's further broken down into acute, subacute, and chronic. Out of those, I chose chronic, kind of assuming chronic irritability status from the celiac medal, even though it didn't really give when in the range of motion he feels his symptoms, but also going based off of his reports of not feeling or not having an increase of symptoms until after longer duration activities. So putting him in this classification, these were some treatment options in there recommended in the clinical practice guideline. Thoracic manipulation, which is recommended for any patient, regardless if they're acute, subacute, or chronic, and even if they're in different classes of neck pain, thoracic manipulation is recommended. But I would want to make sure that my patient feels safe and has a positive outlook on it, which tends to show better results if that's the case. I would also like to do cervical mobilization to restore those limited motions of right cervical side bending and extension. And then I would choose 1 or 2 active range of motion exercises for him to do after mobilization in the clinic, and also for him to take home to reinforce any mobility that was gained with those manual therapy techniques. So these are just some of the few that I would start with, but I would not limit it to these. And then my goals for this patient would be, a short-term goal would be to perform 3 sets of chin tucks to fatigue without reporting an increase in neck pain from his baseline 2 out of 10 to facilitate cervical lordosis and reduce kyphosis. And I would want him to do that in a week. And then a long-term goal I had for him was to report no increase in neck pain again from the baseline 2 out of 10, and then arm pain baseline 3 out of 10 after a typical workday in 2 months. All right, thanks for listening.